Good evening, everyone, and welcome to tonight's webinar. My name is Conrad Stradom. I'm the editor of Medical Academic, and I'm joined tonight by Dr. Leonard Steingo for a presentation entitled Diabetes and the Heart. This webinar is accredited for one general CPD point and is proudly sponsored by Activo Health. Dr. Leonard Steingo is a cardiologist who practices at Morningside Mini Clinic in Sandton, South Africa. He obtained his medical degree at Wits, becoming a specialist physician and then a certified cardiologist. He became a fellow of the American College of Cardiology in 2010. He is past president of the South African Heart Association and is currently on the committee of the Heart Failure Society of South Africa. He has been involved in many cardiovascular research trials as principal and sub-investigator. These trials have been involved with coronary artery disease, atrial fibrillation, and heart failure. More recently, he has been involved in many trials monitoring the heart in patients receiving new chemotherapeutic drugs. Dr. Steingo's special interests are echocardiography, invasive cardiology, and cardio-oncology, which is the assessment and treatment of patients receiving cancer treatment. He practices as a general cardiologist and has accumulated many years of experience treating patients with a wide range of cardiovascular diseases. Here's some guidance for the webinar. If you have a bad connection, please click the button at the top of your screen that says Reconnect. There will be a recording of this webinar available to watch. CPD points are allocated based on viewing time, so please do watch the full presentation. As per HPCSA guidelines, we no longer issue CPD certificates directly, but pass on this data to the HPCSA, where you can view your points on their portal. If you are not registered with HPCSA or you did not complete a registration process in order to access this webinar, please send an email to john.woodford@newmedia.co.za with your name, surname, and MP or P number. The same applies if you're registered in a foreign country like Namibia, Botswana, etc. HPCSA have a backlog of CPD points they still have to allocate, and your points might take a few weeks to reflect. And without further ado, I now hand over to Dr. Steingo.
Yeah, thanks, Conrad. Thanks, Conrad. You can put the first slide on. All right. Good evening, everybody, and thank you, Conrad, for inviting me and asking me to give this talk. So, as you said, I am talking about diabetes and cardiovascular disease, the association, and some of the managements of patients with diabetes who have associated cardiovascular disease. As you know, diabetes and cardiovascular disease are a very common association. My talk will be outlined by firstly a preamble and the diagnosis of diabetes, a cardiovascular risk assessment, how one assesses a patient's risk in patients with diabetes, something about lifestyle management, glycemic targets, atherosclerotic cardiovascular disease risk reduction by glucose-lowering agents, blood pressure and diabetes, lipids and diabetes, antithrombotic therapy and diabetes. And most of what I'm going to say up to this point will be about type 2 diabetes, but then I will say something about type 1 diabetes as well. So as you know, diabetes is a very common metabolic condition. It affects about 2021, it affected about 537 million individuals. That is about a 10% prevalence. And by 2045, it will be about a 12% prevalence in the population. Type 1 diabetes constitutes about 5 to 10% of individuals and is secondary, as you know, to the destruction of pancreatic cells by an autoimmune process. Briefly, individuals aged less than 35 presenting with diabetes should be suspected of having type 1, although, of course, this can occur at any age. So type 2 is by far the most common cause, and 90% of diabetics in the population are type 2 and is usually caused by insulin resistance coupled with relative insulin deficiency, resulting, of course, in raised glucose levels. So we are speaking now mostly about type 2 diabetes. So how does one diagnose diabetes? I'm sure that everybody is aware of this, but just briefly to look at this algorithm, normally one should have a fasting glucose of less than 5.6 milliosmoles per liter, or an HbA1c of less than 5.7, or a 2-hour oral glucose tolerance of less than 7.8. If these values are normal, then diabetes has been ruled out. On the other hand, if these values are indicative diabetes or prediabetes, if the fasting glucose is more than 7 and the HbA1c is more than 6.5, or you have an oral glucose of more than 11, then you are diabetic. If you have a fasting glucose between 5.6 to 6.9, or an HbA1c between 5.7 and 6.4, or an oral glucose tolerance between 7.8 and 11, then you are pre-diabetic. So this is just a simple algorithm of looking at the values that one uses in diagnosing either prediabetes or diabetes. The prevalence of diabetes is increased among patients with cardiovascular disease. There's about a 23 to 37% of patients with acute coronary syndromes will be diabetic, and about 10 to 47% of patients with heart failure are diagnosed with diabetes. So therefore showing the very common association between diabetes and cardiovascular disease. Therefore, all individuals who have atherosclerosis, or if they have heart failure, or if they have atrial fibrillation, they should all be tested for diabetes, and obviously particularly those who are hospitalized. So all patients with any cardiovascular condition should be assessed and screened for diabetes. Now, what about cardiovascular risk assessment in patients with type 2 diabetes? How do we assess a patient's risk, a diabetic patient? How do we assess his risk for cardiovascular disease? So individuals with type 2 diabetes have about a 2 to 4-fold higher risk for developing cardiovascular disease during their lifetime, with all its manifestations of either coronary disease, stroke, heart failure, atrial fibrillation, or peripheral arterial disease. Obviously, patients may develop one of these or multiple of these. It is of utmost importance to screen patients with cardiovascular disease for diabetes and to assess their risk in individuals with diabetes and to evaluate them for either cardiovascular disease and or kidney disease. Again, emphasizing a close relationship between cardiovascular disease and diabetes and the high incidence of developing cardiovascular disease in a patient with diabetes. This is one of the scoring systems that we use. I'm not going to go into any specific detail, but I would like you just to look at the middle part of this diagram where it shows you the original SCORE2 algorithm. Now, the original SCORE2 algorithm was a table which was used to assess patients for cardiovascular risk. It is very similar to the Framingham risk score that we use, and you can see it takes into account the patient's age, whether the patient is male or female, smoking, whether they're diabetic or not, systolic blood pressure, total cholesterol, and HDL cholesterol. So that is the original SCORE algorithm, and that is, as I say, very similar to the Framingham risk score. They then adapted this to patients for diabetes, and how they adapted is they took the original SCORE system and they added predictors such as age of diabetes at diagnosis, their HbA1c levels, and their GFRs. And that is called the SCORE2 diabetic model, and that is a 10-year CVD risk model for patients with diabetes. So this should be used in diabetic patients to assess their 10-year cardiovascular risk. And for example, if you look at the bottom there, it gives you an idea of a newly diagnosed diabetic. Sorry, it's a bit small, but it shows you there a newly diagnosed diabetic, age 60, an HbA1c of 50, which is about 7, a GFR of 90, and this patient would have a moderate risk. You can see that the diagram there shows a moderate risk. And then a patient, for example, who's diagnosed at age 50 with an HbA1c of 10, that's 70 over there, a GFR of 60, that patient would also have a moderate risk. So this is a way of then assessing the patient's cardiovascular risk. It's important in terms of knowing how intensive your therapy should be, the same as when we look at the Framingham score and deciding should a patient be treated or not be treated, for example, with a statin. So if you look at the scoring system, so patients then with atherosclerotic cardiovascular disease, or those who have severe target organ damage, and severe target organ damage depends on their renal function, depends on whether they have albuminuria or proteinuria, it depends on whether they have microvascular disease. If those patients have either established disease or they have severe target organ damage, then they are immediately very high risk. If they don't fit those criteria, then they can then be assessed according to the SCORE2 diabetic system, and they can then be very high risk if their risk is more than 20%. If they have a 10 to 20% 10-year risk, then it is high risk. If it's 5 to 10%, it's moderate risk. And if it's less than 5%, it's low risk. This scoring system can easily be downloaded. It's called the ESC Cardiovascular Disease Risk Calculator. It's easy to download, and it's very easy to use it. It can be used with your patient right in front of you. Within about 3 minutes, you can assess the risk of your patient with diabetes into what risk category he fits. And according to the guidelines then, the European guidelines, those patients with very high cardiovascular risk, in other words, those who have clinically established cardiovascular disease, or those who have severe target organ damage, or those who have a 10-year risk of more than 20% according to the SCORE2 diabetes system, those are very high risk. High CV risk patients are those who do not fit those above criteria, but they have a 10-year risk of 10 to 20%, moderate risk 5 to 10%, and low risk less than 5%, according to the SCORE2 diabetic criteria. So that is a nice and easy way of assessing a diabetic, type 2 diabetics patient risk for having a cardiovascular event in the next 10 years. The SCORE2 diabetic system should be used to guide intensity of treatment, as I said, and additional interventions to prevent atherosclerotic cardiovascular disease, such as lipid lowering, whether you should use an SGLT2 inhibitor, whether you should use a GLPA inhibitor. Agonist. The 10-year risk threshold is for guidance only, and other characteristics may lead to decisions to treat or not to treat, irrespective of such thresholds. So this is a guide, but one should look at other characteristics as well in a specific kind of patient that you're looking at. Remember that guidelines are there for guidance, but one has to look at the individual patient, obviously, as well. And again, these are recommendations from the European Society of Cardiology, and they show here that it is recommended to screen patients with diabetes for the presence of severe target organ damage. So as I mentioned, all those patients then who have diabetes, you should screen them for renal function, albumin-creatinine ratio, proteinuria, and whether they have evidence of microvascular disease such as retinopathy, nephropathy, or neuropathy. It is recommended also to assess the medical history and the presence of symptoms which may suggest that these patients have atherosclerosis. And in patients with type 2 diabetes without symptomatic atherosclerosis, and if they do not have target organ damage, then you should estimate the 10-year risk via the SCORE2 diabetic system. So this is really what I've been saying to you, and these are ESC guidelines and recommendations. And as you know, class 1A is a highly recommended thing that one should do. It is highly recommended. And level A means that there are many trials which then justify this. 1B is a class 1 recommendation. In other words, it's highly recommended. Level B, it means that there may be one good trial, for example, which has justified this recommendation. So these are very high recommendations for screening and assessing patients' risks in patients with type 2 diabetes mellitus. And let's talk something about then the management of these patients with type 2 diabetes. How do we manage them? Firstly, one always thinks in terms of lifestyle management. And a 1A recommendation, in other words, very highly recommended, and many studies support this recommendation. It is recommended that individuals living with overweight or obesity should reduce their weight they should increase their physical exercise to improve their metabolic control and their overall CVD risk profile. So weight loss and exercise, very important. Glucose-lowering medications with effects on weight loss, such as GLP-1 agonists, should be considered in patients who are overweight or obese to reduce their weight. This is currently a 2A recommendation, so it is not highly recommended, but it is certainly recommended. And there are some studies, and there is certainly a study which supports this. And then bariatric surgery should be considered for high and very high risk patients with a BMI of greater than 35. This is a class 2 recommendation. When repetitive and structured efforts of lifestyle change combined with weight-reducing medications do not result in a maintained weight loss. So bariatric surgery as well does have a place in the very obese type 2 diabetic patient. So in terms of diet, the diets that are recommended, and these are class 1A recommendations, are the Mediterranean diet, which, as you know, is fruit, vegetables, fish, olive oil, and other plant-based diets, which are high in unsaturated fats to lower cardiovascular risk. So diet as well, very important, and these are the recommended diets. In terms of exercise, I won't go through this in detail as such, but it is recommended that patients exercise. They should do at least 150 minutes a week of exercise. Obviously, this kind of exercise needs to be adapted to the individual patient. Obviously, if they have peripheral vascular disease or neuropathy, this might need, this might need to be tailored to the individual patient. But certainly exercise is very important, and the use of behavioral therapy is as well in setting goals might be important, and it should also be considered to perform a treadmill test, an exercise test in patients who already have established cardiovascular disease. So remember then, this is for all patients with type 2 diabetes. Exercise very important, tailored for those patients who have already problems, and in patients who already have cardiovascular disease, a stress test should be done to assess the severity of how much exercise the patient can do. So exercise, very important. Smoking, it is obvious that smoking should be stopped. That's a 1A recommendation. And replacement therapies can be used, nicotine replacement therapy, and certain drugs, as you know, can be used to try and improve the patient's success rate of stopping to smoke. So smoking, very important, of course, not to smoke. So lifestyle then is not very difficult to understand but very difficult to implement. And lifestyles, as I've mentioned, such as diet management, exercise, weight loss, and smoking, very important when seeing a diabetic patient to talk about all these lifestyle changes that are necessary to improve the patient's cardiovascular outcome. So let's talk about glycemic targets then in patients with type 2 diabetes. One should try and reduce the HbA1c to less than 7%. This has been shown to definitely decrease microvascular complications. And the effects on the macrovascular disease are more complex, and I will say something about this. So a meta-analysis of many studies, including the well-known UK PDS study, Advance Accord, and the Veterans Administration study, including over 27,000 patients, showed that lowering the HbA1c reduced the incidence of myocardial infarction. But unfortunately, heart failure and stroke in these patients was unaffected in these studies. But there was a decrease in microvascular complications, and these were both renal and retinal microvascular, but not neuropathy. Now remember that these were older studies. They were not looking particularly at cardiovascular outcomes, and they were not using the newer drugs that we now have available. But they did show that getting to a low HbA1c, although it did have some effect in these patients, you did not have a dramatic effect in terms of macrovascular complications, And there was definitely a decrease in microvascular, but not specifically in neuropathy. And then, of course, the ACCORD trial, which is well known, where 35% of the participants had a previous cardiovascular event. This showed an increased mortality in the intensive glycemic arm. So when one got to an HbA1c of less than 6.5%, there was hypoglycemia, and these patients actually did worse. So we know that when you treat patients with type 2 diabetes, although it's important to get their HbA1c levels to less than 7%, episodes of hypoglycemia can be dangerous, and one should be aware and be careful of over-drastic treatment and over-intensifying treatment. And just a simple guide to glycemic controls then in patients with type 2 diabetes who have established cardiovascular disease. In those patients who have a short life expectancy, one should relax the glycemic targets, and if you get to a target of less than 8.5%, that is adequate. But in patients with a longer life expectancy, one should tighten the glycemic targets. You should, as I said, avoid hypoglycemia, and one should target to a level of less than 7% HbA1c. And one should give priority to agents with proven cardiovascular benefit, which I will talk about, and with low hypoglycemic risk. So this is the general targets that we are aiming for in patients with type 2 diabetes, and particularly those who have established cardiovascular disease. Now, what about atherosclerotic cardiovascular risk reduction by glucose-lowering medications? So firstly, as I have mentioned before, but I do want to stress this, is that type 2 diabetes is very common among patients with atherosclerotic cardiovascular disease or those at high risk of cardiovascular disease. In other words, patients who are hypertensive, overweight, high cholesterols, and so on. In other words, high risk. Atherosclerotic disease itself is very common in patients with type 2 diabetes, so the associations are common. As I mentioned, all patients with atherosclerotic cardiovascular disease should be screened for type 2 diabetes. So now, what about the glucose-lowering medications that we use? Remember that they should be prescribed, firstly, to improve cardiovascular outcomes. Secondly, their safety must be taken into account. And thirdly, for glucose control. And underpinning these recommendations are the results from key cardiovascular outcome trials delineating the safety and efficacy of glucose-lowering therapies and their effects on cardiovascular outcomes. So in the past, the trials that were done and the drugs that were used did not specifically look at cardiovascular outcomes. So although we saw that there was some reduction in myocardial infarction, there was some reduction in microvascular disease, these trials were not particularly aimed at this and were not looking at statistically at these outcomes. Whereas the newer drugs that we used and all the new diabetic trials that are being done are looking specifically at cardiovascular outcomes. So let's talk about glucose-lowering medications with cardiovascular efficacy, which have been demonstrated in the cardiovascular outcome trials. Firstly, the sodium glucose transport inhibitors, the SGLT2 inhibitors. A meta-analysis of six SGLT2 inhibitor trials demonstrated a reduction in the primary atherosclerotic vascular disease-based composite of time to first event of cardiovascular death, including myocardial infarction, stroke, in other words, major adverse cardiovascular events. And this was most apparent in patients who already had established cardiovascular disease. So a lot of these trials were then done in patients who already had established cardiovascular disease, and there was a reduction in the next event of either death, MI, or stroke. Just to make a point that neither dapagliflozin nor etugliflozin, which we don't have, reduce the risk of MACE and or reduce the risk, but they did reduce the risk of heart failure hospitalization with consistency across classes for heart failure benefit. So basically, most SGLT2s do reduce MACE and certainly reduce heart failure hospitalization, but in some of the earlier trials, they didn't show the reduction of MACE with some of them. Based on these results, along with GLP-A agonists, SGLT2 inhibitors are preferred glucose-lowering therapies for patients with type 2 diabetes with established atherosclerotic disease, and importantly, independent of glucose control. So that's very important. Although one should aim for a good HbA1c, remember that these drugs reduced major adverse cardiac events and reduced heart failure hospitalization, independent of glucose control, and also independent of background metformin use. Because as you know, our first drug has always been metformin, and then we've added and added on other drugs. So these trials were positive, independent of glucose control or previous metformin use. And in patients with type 2 diabetes now, without atherosclerosis or without severe target organ damage, but with a calculated 10-year risk of more than 10% in the SCORE2 diabetic algorithm. So these are patients with moderate risk, they don't have established disease, they don't have established target organ damage, treatment with an SGLT2 and or GLP-1 agonist may be considered, according to the European guidelines, to reduce CV risk, again, independent of glucose control considerations. So it seems really that most patients who have type 2 diabetes, if they are at moderate risk or they have established disease, should have an SGLT2 inhibitor. And if you look at all the meta-analyses in this forest diagram, if you look at the meta-analyses of all the SGLT2 inhibitors, if you look at the treatment effect versus the placebo effect, there is a positive outcome for those patients on SGLT2 inhibitors with type 2 diabetes. It favors the use of the drug versus placebo with or without background therapy and with or without good glucose control. What about the use of glucagon-like peptide-1 receptor agonists, GLP-1 receptor agonists? There have been 8 randomized, placebo-controlled cardiovascular outcome trials which have examined the cardiovascular safety and efficacy of these drugs in patients with type 2 diabetes who are either at high risk or have established atherosclerotic vascular disease. Now, 5 of these trials demonstrated superior cardiovascular outcomes on the primary composite of time to the first event of cardiovascular death, myocardial infarction, or stroke compared with placebo. These, of course, patients were already on other treatments for the diabetes, and the GLP-1 was added to them. Now, based on these results, along with the SGLT2 inhibitors, GLP-R agonists are a preferred glucose-lowering therapy for patients with type 2 diabetes and atherosclerotic disease, independent of glucose control and independent of background metformin use. So in patients with type 2 diabetes then with disease, you should use both an SGLT2 and a GLP. In patients with type 2 diabetes without atherosclerosis and without severe target organ damage, but with a calculated 10-year risk greater than 10% in the SCORE2 diabetes algorithm, treatment with a GLP-A and an SGLT2 may be considered to reduce CV risk independent of glucose control. So again, the European guidelines are saying for patients with established disease and target organ damage, definitely use both drugs. In patients with moderate risk, you certainly should consider both these drugs. And in practice, really, they should really be used in these patients. Again, if you look at this forest diagram and looking at the meta-analysis of patients who were given a GLP-1 receptor agonist. All the lines are to the left, showing definite improvement in these patients, definite benefit in patients who were then given the GLP receptor agonist. And these were in patients who were either at high risk with target organ damage or at patients who had established the disease. Now, so that is the GLP agonist and the SGLT2 receptor antagonist, which should be used in those patients. This is something then about the other drugs that we use for patients with diabetes, the pioglitazone. So the prospective pioglitazone clinical trial, looking at patients in terms of preventing macrovascular events, they were randomized in this cardiovascular outcome trial to assess the efficacy of pioglitazone in these patients, again, independent of glucose control in patients with type 2 diabetes and established disease. It failed to achieve statistical significance for its primary composite outcome of all-cause death, myocardial infarction, stroke, unstable angina, coronary or peripheral revascularization, and amputation. But the outcome of CV death, MI, and stroke alone, there was a significant 16% relative risk reduction. So there was some benefit then in adding on pioglitazone to a patient with diabetes and atherosclerotic disease. There was some benefit, but not overall a major benefit. And as you know, there is a slight increased risk of heart failure in patients who are given pioglitazone, but it appears to be related to the expanded plasma volume, and there's certainly no evidence of myocardial toxicity in these patients. And based on the data and the net benefit, it is reasonable to consider using pioglitazone in patients with diabetes and atherosclerosis. So it is a safe drug in most patients, although just be careful of not increasing their fluid volume. And then what about patients for DPP-4s? So the DPP-4 inhibitors obviously are very popular drugs as well. There have been 5 randomized trials in populations with type 2 diabetes with or at high risk of atherosclerosis to assess their benefits and their efficacy. And all 4 of these trials demonstrated non-inferiority of the DPP-4 inhibitors, but no superiority in the primary MACE endpoint. So DPP-4 inhibitors are safe to use in type 2 diabetes. They are neutral in terms of their effect on cardiovascular outcome. Insulin, long-acting insulins have been tested in trials with cardiovascular outcome trials, and the 2 basal insulins, insulin glargine and other insulins such as the insulin degludec, the long-acting insulins have been used in trials looking at outcomes, and they didn't really show any benefit in using insulin other than, of course, the glycemic control, but they didn't show a cardiovascular benefit of using these long-acting insulins in terms of, if you look at the last thing over there, over a median follow-up of 1.8 years, there was no significant difference in the primary composite outcome of CV death, non-fatal MI, or non-fatal stroke between the groups using a long-acting insulin for the treatment of these patients, either insulin glargine or the other long-acting insulins. So no benefit for insulin itself. The largest randomized trial using metformin, with the most encouraging cardiovascular results for metformin, was a trial of 753 patients, excuse me, in the UK PDS trial, who either were overweight or obese at entry, comparing conventional glucose targets with a policy of intensive glucose lowering with metformin. So in overweight and obese patients with newly diagnosed type 2 diabetes without previous cardiovascular disease, metformin reduced myocardial infarction by 39%, coronary death by 50%, and stroke by 41% over a period of 10.7 years. So it was a very long study there seemed to be a significant reduction in using metformin to lower your glucose levels. But please remember that in the study, there were only 39 patients who had an infarct, and there were 16 coronary deaths in the metformin arm. So the precision of these efficacy estimates is largely uncertain. I mean, there were such small numbers of events that one needs to be a bit careful of how it is interpreted. But certainly there was reduction, and it was safe to use metformin in these patients. In a meta-analysis of 13 clinical trials evaluating the CV effects of metformin versus placebo or active control, including the data from the UK PDS, none of the differences in assessed CV outcomes was statistically significant. So again, just emphasizing, metformin might be safe for patients in terms of cardiovascular outcome, and it's certainly good for lowering glucose, but its overall efficacy is questionable. In patients with type 2 diabetes and atherosclerosis not treated with metformin, and SGLT2 and the GLP should be given first line. So now they're actually saying in the guidelines that GLPs and SGLT2s should be first line, and that metformin can be considered as an additive drug in those patients who have established diabetes and atherosclerosis. What about sulfonylureas? Relative safety of glycoside and glimepiride is somewhat supported. So those sulfonylureas can be used, either glycoside or glimepiride, and this data suggests that the relationship between hypoglycemia and the risk of cardiovascular events might be one of association rather than causation. In other words, those patients who in the ACCORD trial did badly when they were hypoglycemic and had episodes of hypoglycemia, it may have been due to their vulnerability and frailty rather than the drug itself causing the problem. But remember that hypoglycemia certainly should be avoided. And the drugs that they've tested in terms of safety, the sulfonylureas of glycoside and glimepiride, they can be used in patients, but one should be careful of hypoglycemia. So, in summary, to reduce cardiovascular risk independent of glucose control, use a GLP agonist and an SGLT2 inhibitor, independent of HbA1c. For additional control, add more metformin or pioglitazone. And then other agents which can be added, and they are safe, are the DPP4 inhibitors, sulfonylureas, and the long-acting insulins. So that would be one's choice of drugs in patients with diabetes then and to reduce their cardiovascular risk. I'm going to go on to the next slide and just go on. Let's go on to blood pressure and diabetes. So in the most recent observational research program and Eurospire surveys, so these were surveys which were done in Europe, there was hypertension was present in 80% of men and 87% of women with known diabetes. I mean, that's an extremely high incidence of hypertension in diabetic patients. And 74% of men and 81% of women with newly diagnosed diabetes who had a history of coronary disease were hypertensive. So hypertension extremely prevalent in diabetics and extremely prevalent in diabetics who already have coronary disease. Now, the 2018 ESC guidelines for the management of hypertension recommend that in all patients with diabetes, office blood pressure should be targeted to a systolic of 130 and lower if tolerated, but not less than 120. So 120 to 130 systolic blood pressure, and diastolic should be lowered to less than 80, but not less than 70. And in patients who are older than 70, one should target an office blood pressure of 130 to 140 and a diastolic of 80. So those should be the targets for blood pressure. Hypertension diet should be, again, a Mediterranean diet. It should be a diet rich in fruit, vegetables, and low fat. And the recommended diets are the Mediterranean diet and the so-called DASH diet. And one should increase potassium intake and lower sodium intake. Long-term exercise training is important, and exercise actually leads to a marked improvement in risk factors such as hypertension, dyslipidemia, and diabetes. And exercise and diet are also associated with marked weight loss, which was also observed in bariatric surgery. So again, management of hypertension, diet, exercise, and weight loss. And the treatment we should use, remember that it is recommended to start with combination therapy mostly, and the combination therapy should always include an ACE or an ARB, because evidence strongly suggests that an ACE and an ARB do protect the kidneys in patients with diabetes. So controlling blood pressure often requires multiple drug therapy with an RSA inhibitor and either a combination with a calcium channel blocker or a diuretic. Of course, one in the third block over there, one should consider beta blockers when there is a specific indication such as heart failure, angina, post-myocardial infarction, or atrial fibrillation. So therapy for hypertension in diabetes is very similar to hypertension without diabetes, but remember the targets that I mentioned and the drugs that we should use. And then in a select group of patients who are resistant hypertensives, and when I talk about resistant, that would include a calcium channel blocker, a diuretic, and plus an ACE or an ARB, and something like aldactone. In a select group of patients with resistant hypertension, and a lot of patients with diabetes have HFpEF, that is heart failure with preserved ejection fraction. About 61% of diabetics with hypertension have HFpEF. These patients do well with a combination of sacubitril, valsartan, that is Entresto. So if those patients are still resistant and use an ACE or an ARB, you use a calcium channel blocker with it and a diuretic with it and aldactone with it, you should change the ACE or the ARB to sacubitril valsartan. In terms of lipids and diabetes, there are a cluster of lipid and apolipoprotein abnormalities which accompany diabetes. Patients with diabetes usually have a high triglyceride level. They usually have a normal to mildly elevated LDL, and they have a low HDL. That is the typical profile of a patient with diabetes. And in terms of recommendations for lowering lipids in patients with diabetes for cardiovascular risk protection, and this table looks at CV risk categorization then in patients with diabetes with atherosclerosis or severe target organ damage, and again looking at the score 2 diabetes. Remember, if the patient has established atherosclerosis or severe target organ damage, they should routinely have lipid lowering. And then you look at the score 2 diabetic algorithm. If they're very high risk, then the LDL should be less than 1.4. So that is established disease, or with a score 2 of greater than 20%. Or if they're very high risk, you should look at an LDL of less than 1.8. And if they are moderate risk, with a 5 to 10% score 2, then you should look at an LDL of less than 2.6. So established disease, definitely treat. And then look at the score 2, as I said, very high risk, and moderate risk, LDL less than 1.4, less than 1.8, and less than 2.6. In those various categories, that is what you aim for in treating these patients with lipid abnormalities. Statins remain the first-line therapy to reduce LDL in patients with diabetes. Adding ezetimibe is very effective because patients with type 2 diabetes have increased absorption of cholesterol, so it has a very good effect. And then, of course, the new drugs such as the PCSK inhibitors, such as Praluent and so on, such as evolocumab and alirocumab, those drugs, the PCSK9 inhibitors, can be added to ezetimibe and statins to reduce the LDL if necessary. But the mainstay of treatment, statins and ezetimibe. And then fibrates are not very useful in patients with diabetes and even with abnormal triglycerides. But the drugs which should be used if their triglycerides are still high are the omega-3 fatty acids, and the best ones to use is the eicosapentaenoic acid, 2 grams twice a day, in patients who still have a very high triglyceride level. And then there are new cholesterol-lowering drugs. There's inclisiran, which will be a twice-a-year drug, and there's bempedoic acid, which can be used instead of a statin in those patients who are statin intolerant. So these are some of the drugs which one should use in patients to lower their lipid levels. In terms of antithrombotic therapy, the only thing I really want to say, all patients for secondary prevention should have aspirin. In other words, established cardiovascular disease, atherosclerotic disease. But in terms of primary prevention, there's a lot of information now that in patients, aspirin should not be used for primary prevention, except for patients with type 2 diabetes. Aspirin can be considered because they are at high risk of developing cardiovascular disease. And this is just a diagram showing you why patients with diabetes do develop atherothrombosis, because they have increased inflammation, they have increased platelet turnover, they have endothelial dysfunction, they have other risk factors such as hypertension, smoking, obesity, and dyslipidemia, and all this leads to atherothrombosis. So aspirin should be used in established disease, and it should be used in patients with diabetes who have other risk factors. Let me say something briefly about type 1 diabetes. I've been speaking now mostly and only about type 2 diabetes, but remember that patients with type 1 diabetes also face a 3-fold increase in mortality compared with the general population, which translates to an 11-year reduction in life expectancy. And cardiovascular disease, even in patients with type 1 diabetes, accounts to 30 to 44% of all deaths. So that reducing cardiovascular risk in patients with type 1 relates to both lowering the HbA1c and controlling other cardiovascular risk factors, including blood pressure and LDL. Near normal glucose control reduces the incidence and progression of microvascular complications, and intensive diabetic therapy in type 1 reduces cardiovascular complications. And when one looks at the treatment of type 1, it should be the same as in the treatment of type 2. There's no reason that the treatment should be different from type 1. In other words, lipid lowering, blood pressure lowering, aspirin, and other anticoagulants for type 1, except, very importantly, the use of GLP-A agonists and SGLT2 inhibitors are not recommended in patients with type 1 diabetes. That is very important. If you look at the last bar in this diagram here, for glucose-lowering agents, GLP agonists and SGLT2 inhibitors are currently not indicated for type 1 diabetes as opposed to those for type 2. Exercise and lifestyle at the top there, very important, improves HbA1c control. Blood pressure, patients with type 1 diabetes target 120/80. Lipid lowering, statins still remain the cornerstone. Add ezetimibe if necessary, and aspirin, as I've mentioned, the antiplatelet therapy. Renal protection in type 1 diabetes, ACE inhibitors and ARBs are very important. They prevent kidney failure in patients with type 1 diabetes, and they should be and they're recommended in patients with type 1 diabetes as soon as kidney damage is first clinically evident. So this is a brief summary of how to treat patients with type 1 diabetes in terms of preventing cardiovascular events and the renal protection. Remember then that diabetes should be person-centered care. The person with diabetes, the family, the caregiver, cultural, social, all those entities should be taken into account. It should be an interdisciplinary team approach. Physicians, nurses, diabetologists, psychologists, physiotherapists, nephrologists, cardiologists should be involved. And of course, communication, amongst patients, relationships, education. In other words, a holistic approach to the treatment of patients with both type 2 and type 1 diabetes. Thank you very much for listening. That is the end of my talk. Thank you, Conrad.
Doctor, we've got some questions already.
Okay.
The first one is, talking about the Mediterranean diet, what is doctor's comment on the Banting diet in cardiovascular disease, diabetics with cardiovascular disease?
The Banting diet, I'd rather not hear the word. My comment is that is absolutely an incorrect diet to use in any patient, in any situation, unless it's short-term to lose weight. And even in that situation, any low-caloric diet, whether it be Banting, low-carb, low-protein, patients will lose weight. But Banting diet is a terrible, dangerous diet. Any further questions?
Yeah, sorry. Please comment on bexagitazone or agitazone in diabetes and heart disease.
What is that, sorry?
Bexagitazone or BEX agitazone. Do you know the drug?
I'm sorry, I don't know the drug.
All right. If the person that asked that question could just maybe clarify. I don't know if that's
that. I'm sorry, I don't know that drug.
Okay, sure. Next one. Please let me know about mortality risk of a well-controlled 76-year-old diabetic only on metformin.
So mortality risk, say that again.
Mortality risk of a well-controlled 76-year-old diabetic that's only on metformin.
Yeah, so I mean, look, in a 76-year-old who's on metformin, as I mentioned earlier, it certainly is safe for the patient. I mean, it's not going to increase their mortality. There might be a slight decrease if they're overweight, particularly if they're obese. But even in that kind of patient, if they've got established disease, one should add an SGLT2 and, if possible, even a GLP-A. So yes, it's safe to use it, considering, of course, that the renal function is adequate. But yeah, it can be used, and I don't think it's that much benefit. Slight benefit, maybe, in obese patients.
Sure, thank you. I'm trying to understand this question. I think what they're referring to, they want to know your comment on the supply shortage of
Ozempic.
Yeah, I think that's what they're talking about, yeah.
The supply shortage. Yeah, the supply shortage is a problem because obviously people are using it off-label for weight loss and not using it particularly only in diabetics. The recommendations, of course, are for patients with diabetes and not for patients and for weight loss with diabetics and patients that people are using for everything. But the guidelines are going to change, and I'm pretty sure in the future that the GLP agonists are going to be recommended for weight loss alone, even in patients who are not diabetic. So it's a big problem. I mean, you can't get hold of that drug at the moment. In fact, it's very difficult to get hold of any of the GLP agonists at the moment because of their off-label usage. Yeah, it's a big problem. I mean, I'm not sure what the answer is, but yeah, I agree. It's a big problem.
Thanks. Should we just give statins to all diabetics before they develop detectable end organ damage?
Yeah, I mean, all type 2 diabetics should be on a statin, definitely. I think there's very little reason not to. And then you should, as I mentioned, established cardiovascular disease, definitely. Target organ damage, definitely. And then you score risk the patient according to the SCORE2 diabetic algorithm. And according to the score risk, you'll decide on the statin intensity. High risk, very high risk, less than 1.4 LDL. High risk, less than 1.8. Moderate risk, less than 2.6. So yes, I mean, most patients with type 2 diabetes should have a statin. We all.
Thank you. Can an SGLT2 inhibitor be used in conjunction with a DTP inhibitor?
Yes,
Yeah.
most certainly it can be.
Okay.
It
In
probably should be. And independent of glucose control, as I've emphasized, independent of HbA1c level, those drugs are fantastic in patients with established atherosclerotic cardiovascular disease. All the outcome trials have shown benefit.
Thanks, Doctor. What's the role of colchicine in diabetics with ATCVD?
Okay, so specifically the role in diabetics, I mean, I don't think that's partly the point. The point is, what is the role of colchicine in chronic coronary disease, which is what you're alluding to. And there is some evidence now that in patients who have chronic coronary disease, that colchicine should be added to their usual regimen of statins and so on. I don't think that's taken on very much at the moment, but I think in patients with coronary disease who are kind of not well controlled, they come back with an acute syndrome and so on. Those kind of patients, probably one should add colchicine. I mean, that's the kind of patient that I'm starting to add colchicine. But that doesn't specifically apply to diabetics. That applies to all patients with atherosclerosis, coronary atherosclerosis.
Right, thank you. Does the risk of heart disease already increase in the pre-diabetic stage?
Yes, it does, yes. Good question, and yes, it does. Pre-diabetics also have a higher risk of cardiovascular disease. And they should be looked at in the same way and managed in the same way as diabetics. One should look at their score 2 diabetic risk and treat them accordingly.
Okay.
Excuse me.
How do you manage isolated hyperinsulinemia?
You're probably asking the wrong person. I mean, it's not specifically my field. So I can't, as I say, you're asking the wrong person. I'm sorry. I can't really answer that question.
Sure, no problem. If there are any more questions, could we please type them in the Q&A section? Otherwise, I'm going to try something different. I see there are a few people with their hands up. So I can allow some people into the to speak directly to Doctor. So Tasneem Omar Sidat, if you've got a question for Doctor, please go ahead. I'm going to just have your mic on if you like.
Yeah, hi. Yeah. I'm listening.
I don't know if they've joined yet. Tasneem Omar Sidat.
I don't know if the mic is on.
Okay, no, never mind. I think that's fine then. Any other further questions? No, here we go. Thank you so much, Doctor. Yeah, great presentation.
Thank you. Thanks, everybody, for listening.
Thank you very much. Thanks, and thank you also to Activa for sponsoring this presentation.
Yes, thanks very much to them as well. Appreciate it.
Thank you to everyone that joined tonight.
Hope it was useful. Thank you. Good night.
Thank you. Cheers.
Good night. Good night.